Hello, welcome. Welcome to our session on traumatic brain injury. I invite everyone to come and take a seat close in the front. We're in for a very interesting session. We're very lucky to have 4 amazing speakers. We're going to get right to it. First speaker up is Marek Mirski, who's anesthesia from Johns Hopkins University, and he's going to talk about the heterogeneity of the disease.
Hello, thank you again for inviting me here. I'd like to talk about traumatic brain injury. Of course, the first talk always should be about the basics, which this is. What I want to say, first of all, that traumatic brain injury as a topic or as a diagnosis is very difficult to package into one sort of phrase because TBI encompasses a very wide spectrum in CNS pathology. It is a systemic injury as well. It is very rarely limited just to the brain, and of course the brain talks to every organ system beyond, so damage to that organ often impacts how the other organs function. So the classic throw the melon off the roof onto the ground is not a very good analogy for TBI. And keep that in mind also when we're talking about different trials regarding the inclusion of traumatic brain injury as one inclusive group. It is a very heterogeneous entity, so it's very, I think, difficult to lump that kind of single diagnosis and then expect that one sort of modulated therapy is going to impact all those elements. So there may be subgroups that behave differently, and so just keep in mind it's a very heterogeneous system. The only thing from the structural principles, which I know you know very well, that I want to sort of focus in on is, number one, this is an enclosed case, unlike many other organs in the body. And secondly, that the brain is in fact surrounded by a thin layer of spinal fluid, which you all know, but perhaps you don't realize that the reason that there is primarily to protect the brain. It actually makes the brain seemingly float within the calvarium. And because of that, it reduces the effective weight of the organ down to about 50 grams. So the neurons at the base of the brain are quite happy sitting there just above the skull base and not being squashed by another kilogram of tissue. But also in terms of trauma, it protects the brain from getting bashed from the inside aspects of the bony calvarium. When we talk about brain injury with primary trauma, and of course, we're talking about traumatic, so these are the sort of common ways to injure the brain, including concussions, fractures, contusions that result in intracranial hemorrhage, and of course the coup and contra-coup injuries, which are the classic, and these can come from either concussive, and we'll talk about it shortly, also blast injuries. And then we have diffuse axonal injuries, which is the classic whiplash, and penetrating injuries from bullets, projectiles, etc. And again, I'm sure this audience knows very well that the primary injury is serious enough, but often is the case is that the secondary injury can be actually much more severe in terms of the total volume of neuronal tissue affected by the severity of this sort of secondary phenomenon. This is just a incidence sheet of how traumatic brain injury affects the civilian as well as the military population. The usual well-known elements here to the civilian population are known. In the military, the only difference is that the moderate to severe head injuries tend to predominate more so than in the civilian counterpart. And again, in the military counterpart, you have this one entity which is pretty much absent from the civilian cohorts, and that is the explosive or blast injury. Moving on to the classic coup, contra-coup, TBI. This is commonly seen in every trauma ICU and neuro ICU where there's 2 impacts associated with the primary insult. You have either the brain is moving in a direction and getting hit by a stationary object, or a moving object is hitting the stationary brain. Either way, it results in the brain being jostled inside the vault. Now here's where the fact that the brain is actually less dense than the CSF, it is floating. So the injury, interesting pathophysiologically, is a bit different than what you might initially expect. When you have a moving brain, for example, hitting a windshield, the primary force at the time of impact causes the cerebral spinal fluid to actually rush ahead of the brain and actually buffer the impact of the brain onto the inner table of the skull at the point of impact at the windshield. It actually then takes the CSF away from the backside, so the secondary force backwards, when it's jostled, causes the occipital part of the brain to hit the inner calvarial table with all its protuberances, and that causes an injury contralateral to the primary intact point. And then the brain again pushes again forward, and then you have actually the coup injury, which happens typically after the contra-coup injury. This is a good example of a coup contra coup. On the right, you see a CT scan, which very commonly you see at the coup site all of the primary impact point injuries, such as galeal swelling, potentially a fracture at the skull, and then also the classic subdural, even epidural hematomas form. But look closely at the brain substance beneath the subdural, and you see that tissue injury doesn't seem to be as grossly affected as the contra-coup lesion, which is actually a contusion within the brain tissue itself. And so this actually may be, in terms of morbidity long-term, more affecting the patient than the primary site of injury, of impact. Here's another impactive CT showing clearly this is the site of impact with a very swollen galeal tissue. There may be a fracture here, I don't know. It's not, the CT scan's not made to look at that. But look again at the contra-coup site. You have worse than the direct impact site, and you almost always have the vulnerable inferior frontal lobes affected because they sit right over some very bony protuberances of the frontal skull table, and their jostling often causes trauma, even if it's not directly a frontal injury impact. The classic whiplash, as you know, is the sort of, as I usually say, it's the popsicle or Tootsie Roll stick phenomenon, where the torquing of the brain in a rapid acceleration-deceleration phenomenon causes the maximal torque right at the base of the brain, which is right at the brainstem and upper spinal cord areas, causing stretching, and that sort of distorts and finally tears at the axons that are running up and down from the brain to the spinal cord. These injuries also, not uncommonly, can be associated with the coup contra coup injury, because again, maximal acceleration deceleration of the brain can also lead to concussive phenomena up there. Under CT scans or even MRIs, the evidence for diffuse axonal injury is sometimes sparse. Certainly in CT scans, best we can hope for is usually some modest amount of parenchymal dot hemorrhages from blood vessels being torn, if you will. And under MRI, we have different modulations using like radioecho techniques, which bring out the hemosiderin levels, and we can pick out even better the minute hemorrhages associated with whiplash injury. But the best, of course, evidence for diffuse axonal injury is pathology. And here you see the axonal beating, which is from the maximal stretching and tearing of the axons, causing them to disperse their product here, and you have axonal bulb formation, which is characteristic as well of the neuron cell itself being damaged. Blast injury is interestingly very similar to the coup contra coup phenomenon of getting hit by a baseball bat or in a motor vehicle accident, except here we're talking about a pressure wave. And there are differences here between the classic coup and contra coup phenomenon, but the injury is often similar. Here you have a strong blast, frontal impact here, penetrating, going front to back across the calvarium. Here is just a graphed comparison between total injury and the length of the impact of injury pressure. So the greater the pressure, the greater the result of a mortality injury, and of course, the longer the duration of that pressure peak, the more likely the patient's not going to do well. Now, when this pressure wave crosses from front to back, what you'll notice here already is that as the pressure wave gets to about midline through past the calvarium, you see this very blue area, which is actually a very low pressure region forming from the blast going around the brain and finally enveloping it. This low pressure area actually is sort of the contracus phenomenon. That low pressure area causes what we term cavitation, which then leads to tissue injury. This is just a diagram of over just a couple milliseconds time, and this is a very fast impactive time period of just tenths of milliseconds. From the time of the pressure wave hitting, enveloping around the brain, you see a low pressure cavity here, and then following that, you actually see a very large upswing in pressure as the full pressure wave consumes the entire calvallar vault. So here is sequence of propagation. Within about a tenth of a millisecond after the pressure wave hits the front of the head, you have the early parts of cavitation already occurring, and within about a full millisecond later, it's all done. So that injury is occurring. And often, just like with this classic contra coup injuries, the occipital cortex may be worse off for wear than the front, just because of the kinetics and the phenomena of the blast injury. Finally, we get to gunshot injuries, which of course no one wants to deal with, certainly not us in the United States. Geez, wonder why. Gunshot injuries are interesting only because of the physics behind them. The impact severity is typically related to the kinetic energy, which includes the mass, the velocity, and also the shape and the angle then come into play as well, more so for the slower moving velocity bullets. Velocity is more impactive than the mass itself by the equation, so the high velocity instruments of death are much more injurious to the brain tissue and calvarium than you would think, just because they are so much faster. As you can see here from a velocity perspective, it takes about 50 millimeters per second to penetrate the skin. 65 will get into the bone, and as you go up in terms of these types of weaponry, you get up into the high velocity level of over 600 to 700 millimeters per second. This is the category that causes the very additional types of severe injury. Notice that at greater than 700, we're talking about blast type consequences. So that's another level of injury added to the fact that there's a piece of metal piercing the brain into the tissue. So the gunshot injuries can also be devastating, not just from the kinetics itself, but also the type of bullet that's given. The slower ones that are dum-dum or devastated bullets can actually, they transmit most of their kinetic injury on impact. So the local tissue site at the point of entry is what those types of bullets are designed to create maximal devastation. But as you get up in velocity, you lead to this cavitation, which leads to a large exit wound and with a perforating injury. And the fact that a rapid speeding bullet going through the brain tissue, which is little more than the density of tapioca pudding, this leads to a secondary effects of back and forth, sort of waves of transmission of energy. So you're dealing with not just a consequence of one pass and you're done, but over more tenths of milliseconds and beyond, you have undulating further tissue destruction. So TBI etiologies are various, which I mentioned before, leads to the fact that TBI should be considered a very heterogeneous mixture because morbidity and mortality from these type of injuries varies tremendously. These are the type of forces that come along with the various types of primary injury. The brain is, initially at least, protected by the floating mechanisms which help us actually live day to day without subjecting our brain to trauma. The penetrating injuries, of course, add additional injury components, and of course, remember that it's the secondary injuries that almost always are as bad, and it can be much worse in terms of impacting more mass or volume of tissue. Thank you.
Are there any questions? Thank you very much for your excellent presentation. I had a question in terms of monitoring, deciding, for instance, where you will monitor these patients in coup and contre-coup. Would that influence the position or the localization of your monitor, if you're using invasive monitor, for instance?
Well, you go back to the first thought of what you're trying to monitor. As we heard this morning from Giuseppe nicely, we usually put the monitor in the tissue that we feel is at risk.
Okay.
There's probably less utility in putting into areas of brain that already overwhelmingly been shattered. So we usually try to pick an area that is nascent and in good shape, and we usually try to pick the right, but all given measure, you're correct in that with coup and contre-coup type diffuse sort of injuries, you may just have to try to pick what's left.
Yes. Could you tell us more about what is the difference between brain density being less than the CSF density you said?
Yes.
Because I believe they're almost the same.
They're very close, but they're not the same.
1.0081 and 1.00 something.
Yeah, but the brain floats. We'll be buoyant because of that. But it is just a little, because of the fatty nature of brain, it actually will be less dense than the water itself. So it's actually an amazing phenomenon that such a thin layer of CSF can be so important in terms of protecting our day-to-day existence, because the skull is very, very hard, and the inside table has many protuberances that our brain does not enjoy hitting with any force.
Okay, thank you so much, Dr. Mirski. Next up, speaking about TBI in pregnant patients, is Chiara Robba from University of Genoa.
Thank you, and good afternoon. Thank you for being here, even if it's 5 p.m. And I'm sorry that I have to discuss a topic on which, at the end of the story, the truth is that we don't have any evidence, because if you look at any study on TBI, but not only on TBI, the exclusion criteria is basically being pregnant. So we don't know. Oh my God. Well, we can wait for the technical guys. Oh, very good. So this is my conflict of interest, which has nothing to do with this talk. And if the slides work, let's start with a bit of epidemiology. So the good news is that trauma and TBI in pregnant patients are not very common. It can happen that you won't see any of these in your career, especially if you have a short career. But the truth is that when it happens, the problem is that these are young, healthy patients, and that there is the baby. And the mortality of these patients is very high, but the other problem is that also the fetal mortality is very high, which is up to the 60 to the 80% of the cases of maternal TBI. This is the most recent systematic review regarding the epidemiology, the management, and the outcome of these patients. I really like this on and go. It's a seizure test. By the way, this is the most recent, I promise it is. It is the most recent systematic review on this topic, and you might have read the new data from the Center TBI study, which have demonstrated that the TBI population is changing. TBI patients are more elderly, and most of the TBI are because of falls. And obviously, everything is different in pregnant patients because the median age of these patients is around 25 years, so they are generally very, very young. In the majority of the cases, the trauma happen in the third trimester, in 44% of the cases, which makes somehow our decision easier, but in nearly the 30% are in the second trimester, which is, makes things difficult in terms of understanding the priorities. Most of these patients have a TBI because of car accident, so not because of the falls. Most of these have severe TBI, so when it occurs, the trauma is mainly a severe TBI with a reduced GCS and status of coma, and as you see, the outcomes are really bad, especially regarding the fetal outcomes. The other difficulty is that we have to face with a pathophysiological body that is different from any patients that we normally see. We have to take in considerations that pregnant patients have some physiological changes, and according to the state of the pregnancy, these changes are more or less pronounced. At the level of the brain, there are just very few studies, but there are changes regarding the autoregulatory curve, so there might be doubt regarding the CPP target. There might be doubt about the ICP targets, because it seems from TCD studies that pregnant patients have a more swollen brain physiologically. There are a lot of differences in terms of cardiovascular function, heart rate, cardiac output, etc. There are differences in the ventilatory function. They are more difficult to be intubated. For example, laryngeal edema is more frequent. They have a higher risk of aspiration during the intubation, and they have a different clearance of the drugs. So the problem is that we are facing a case like this, and that is why I promise again that this slide says that there are specific guidelines regarding some components of the management of pregnant patients, and one of the majority of the studies in these topics are regarding the airways, because if you see the incidence of failed intubation in pregnant patients, it's much higher than in non-pregnant patients. But especially what is much higher is the risk of and the possibility of them not to be ventilated. So it's been created a few years ago, a specific protocol for the management of the airway in this population, which basically says that you have to try more early the use of supraglottic devices and the use of advanced airway devices. The other general principle and issue is that it's much more difficult in these patients to maintain the hemodynamic stability, especially in the third trimester when you have a compression of the fetus on the inferior cava. This might seem basic, but if you look at this data, in this study, the stroke volume and the cardiac output were evaluated at different positions, and in the supine position, the reduction of the cardiac output is over 30%, so it's really huge. So it's very difficult to manage these patients, and that's why one of the first suggestions is to put the uterus, to move the uterus on the left side. So some principles for management of TBI are the same of a general population. Treat the mom to treat the baby, because the majority of the effect, detrimental effect of the baby are related to hypoxia, hypovolemia, acidosis, which is related to these factors occurring to the mom. And then consider specific situations, and what you have to do in first instance is to understand that there are 2 patients to be treated, and therefore there are 2 patients to be monitoring. So fetal monitoring is fundamental in this case. This is a nice practical algorithm, which describes a general, I promise again, that it describes the general management of these patients. After the primary survey, we need to start to think about the priority. And regarding the priorities, we need to understand the gestational stage, and we need to understand whether the fetus is viable or not. If the patient has not surgical lesions, might need to go for ICP monitor, and here you have to consider whether the patient should go for a cesarean section, and here are the priorities according to the trimester of pregnancy, from the pre-hospital to the operating room and the post-operative care. The general concept is that in the first trimester, the fetus is generally considered not viable and the priority has to be given to the mom. Otherwise, if we are in the third trimester, we need to try to give a priority to the fetus by, in the majority of the cases, considering if the fetus is ready to do a cesarean delivery and then treat the mom. The problem is when the mom is around the second trimester where the fetus is viable, but at the end, the risk of treating the mom considers also the risk of treating the baby. We have recently started a survey, an international survey, which is called MAMA survey, with a great fantasy, which is still ongoing, so I kindly ask you not to take pictures. These are the preliminary results, and basically we asked to the responders how would they treat TBI pregnant patients, and first of all we asked whether the responders have a specific protocol for TBI in this population, and 90% said no, and 10% said not sure. Nobody said that they do have a specific protocol. And again, probably because the incidence of this pathology is very, very low, but at the same time, because it's very low, when we face this kind of situation, we generally don't know what to do. Everybody agree regarding the fact that we need to monitor the fetus, but there is a lot of heterogeneity regarding the type of monitoring. Most of the centers would use ultrasound assessment. Cardiotocography is used in the 30% of the cases. Only the 10% it is used, both of these techniques are used together. And then there are some concerns in these patients. To be honest, everything that we do in these patients is a concern. Starting from the sedation, when we give a sedative or we give drugs to these women, our first question is whether we are doing something bad to the fetus. And here is the Food and Drug Administration classification for drugs in pregnancy. As you can see, there are 5 types of drugs, from absolutely without risks and contraindicated in pregnancy. And as you can see here, the majority of the normal drugs that we use for giving anesthesia, for giving analgesia, are not in the X, are not completely contraindicated during the pregnancy, but are not even without any risk. And going more in the details, the general principles of a pharmacological treatment of this patient is that the lower is the time of the effect of the drug, and the best it is, obviously, for the effects on the fetus. Morphine, for example, can release histamine. It's not teratogenic itself, and the fentanyl is not teratogenic itself. And also remifentanil is not teratogenic, but it has a shorter action. Benzodiazepine is not clear. They might have a teratogenic effect. They have been associated with a risk of some malformation, but especially they have been associated with a risk of respiratory depression and floppy baby. Lower risks are related to the administration of the propofol. Dex, there are really few studies. The risk is that it gives hypotension and bradycardia and effect on the baby. Ketamine, the major risk is that it can give a contraction of the uterus, whereas cisatracurium and other neuromuscular blockers are generally do not give any problem during the pregnancy. The other big question in these patients, the other concern that we will have is how to do the neuroimaging progression. And these are the radiological risks, of course, as it is quite obvious to understand. The major effects are before the 25th week of pregnancy, especially regarding the risk of embryonal death or alteration in the CNS. After the 25th week, the major risks are related to hematological pathologies. But if you look at the risks, the amount of RADs which are required to give an effect, a detrimental effect on the fetus, we are around between 5 and 15 rads. And here you can see a list of the dose of rads for each type of neuroimaging, or imaging and neuroimaging. And if you see a CT head is not that bad. I mean, it means that probably if the mom needs the study, CT has to be our first choice, because we have to make the diagnosis and it's quite safe. And even if we need, this is a case series of artery aneurysm treatment, so higher amount of radiations, pregnant patients, the total dose, if the abdomen is protected during the radiological procedure, does not go above the 5 rads. So again, if the mom needs the study, the mom needs the CT, for the definition of a pathology, we have to do it. Don't be scared about getting a CT. Obviously, the other option may be the MRI, but don't forget that we are in the initial phase where the patient is unstable. It's not that easy to take it to the MRI, which is a longer procedure. So I will personally go initially at least for a CT. And this is what we have asked in the survey as well. And in fact, 80% of the responders will go mainly for a CT as a neuroimaging of choice. Another 20%, another 15% will go for the MRI. I was about scared because in 10% of the cases, the physician would use a cerebral ultrasound, which is not the gold standard, and I don't think it is worth it in this situation. ICP monitoring, these are the results of a synapse ICU study that we did with Professor Giuseppe Citerio, which demonstrated that having an ICP and treating high intracranial hypertension may improve the patient's outcome. And we asked to the responders if indications for ICP or if a threshold will change if you are facing a pregnant patients. In the majority of the cases, threshold and this indication for ICP will not change. There was a lot of heterogeneity in terms of the target of CPP, and some of the responders said, I will be more scared of an hypotension. Some others will say, I will be more scared about an hypertension. It depends on the gestational age. And then there is the clinical management of intracranial pressure. These are the Seattle guidelines. And as you know, this is a staircase approach. And for each staircase, there are some tiers with increased aggressiveness. And for each one of these, in pregnant patients, we need to do some special considerations. In fact, this is an editorial that we wrote with Giuseppe Citerio some years ago, and it was made with the aim to assess the fact that for each step there are increased risk, and we modified this staircase approach in pregnant patients, keeping in mind that there are some components where probably the risk, the additional risk are not so bad, so basic management, even the compressive craniectomy, but there are much more concerns regarding, for example, the use of hypothermia, barbiturates, and controlled hyperventilation. So these are the tiers. So if we start, for example, from the tier 0, which basically says keep the physiology of the patients, true, keep the physiology of the patient, but don't forget that these patients have a different physiology. So when you consider the ghost cup, the factors which basically consider to do a good general intensivist management of these patients, you have to keep in mind that these patients might have different needs. And if you look at the results of the survey, we were a bit surprised to see these results because we don't have any evidence, but just for clinical thinking the responders will keep higher values of target glucose compared to non-pregnant patients. They will keep higher values of hemoglobin, maybe because they are more scared about anemia. A lot of confusion about the CO2, probably because, according to the comments, the effect of CO2 on the placental vascularization is, may result in vasoconstriction and vasodilation, so a lot of heterogeneity regarding the targets of CO2. And they will keep higher values of PaO2. But again, this is not related to any type of evidence. Tier 1, so step 2, osmotic therapy and antiepileptic drugs, compared to non-pregnant patients where there is more heterogeneity in the type of drug used. Levetiracetam is the first choice because it has less effect on teratogenic effects. No difference regarding the use of osmotic therapy. Those who would use hypertonic in non-pregnant would use hypertonic even in non-pregnant. The issue is about the hyperventilation. If you look at these results, for example, in non-pregnant patients, the majority of the responders would use hyperventilation if needed to control ICP, but not in pregnant patients, probably again because of the fear of having an effect in the placental vascularizations. And then there are the tier 3 therapies. So barbiturates, decompressive craniectomy, and hypothermia. We did this sub-analysis of a synapse ICU study, which gave us the signal of the fact that using and being aggressive in the TBI population can improve potentially the outcome. How do tier 3 therapies are used in pregnant patients? If in non-pregnants there is a more heterogeneity, in pregnant patients decompressive craniectomy is used much more often because of the fear of using barbiturates and hypothermia in this population. And then a very last second, when things go wrong, don't forget that, for example, if the mom has a brain dead, there is still the possibility to treat and to maintain the baby. This is a systematic review of 30 cases of brain dead of pregnant patients, and I was very surprised to see the median time of support, which went from 38 to 107 days. So even long support are feasible. And of course, the outcome of a baby depends on the gestational week. So the outcome is much better above the 28 week, but it's still feasible to do this to try to save a baby, and as soon as the fetus is viable, a cesarean section should be done. So in conclusion, it is different, TBI in these populations. Targets are different. Basically, the problem is that we don't know why, because we don't have any evidence. And maybe, even if it's a rare condition, we should consider about adapting the Seattle guidelines to this population. Thank you for your attention.
Thank you so much. For the sake of time, I have a million questions. It was a fascinating, very important, unique talk. I hope we can save the questions for the end, if that's okay. So the next speaker is, actually we're switching the order, Giuseppe Citerio, who needs no introduction, but who is from Monza in Milano, and he will be talking about extreme therapies.
Thank you, Jean. We decided to switch the two presentations because discussing about the outcome will be the last part by David Menon. And so I will discuss about extreme therapies in TBI. Some point has been touched already in the previous talk. I don't have any conflict of interest for this talk. What we are talking about when we say extreme therapies in TBI, we have to return back to the consensus that has been developed in Seattle. These are the two main papers come from the consensus. They are open access. If you don't have them, you can go and download from intensive care. And the aim of the consensus was to build up a tier, 3 tiers of therapies according to the risk of each of the strategy we are applying to the patient. And we can arrive to the higher level, tier 3, in which barbiturate, decompressive craniectomy, and mild hypothermia are contained in this box. This means that the patient pass through all these stages. So we have CPP optimization, sedation, osmotic. We discussed osmotic therapy this morning. We have a CPP test, mild hypocapnia. And we go there only when all the other steps are satisfied. And if we look at the option we have only 3 options at this stage, not so many. And all of them have a different level of evidence behind. If we discuss about barbiturate, the first thing is that the mechanism we are using is the reduction of metabolism. That means that you need to still have some metabolism to reduce. And reducing the metabolism due to the coupling of flow and metabolism, you will reduce the cerebral blood flow and the content of blood inside the skull. But we have a lot of severe side effects that reduce the use of barbiturates nowadays, hypotension, cardiological depression. We can manage them. There is changes of serum potassium that goes down when you start the infusion, goes up if you stop the infusion too fast, an immunodepression, infection, and the main trial is quite old. And if we look at the trial that has been published in 1988, most of you were not born at that time, as you can see, Heisenberg was so smart because he defined two settings, the opening skull and the closed skull. And along with the level of ICP, they start discussing about timing of exposure. But if you look at the result, barbiturates are effective to reduce ICP. And the Claudia Robertson group demonstrated that the biggest reduction of metabolism is in patients with the higher metabolic rate. So you need to test it, and if it doesn't work, you have to stop it because you need to depress, reduce some metabolism. And we can use also EEG for titrating the dose. So we cannot increase the dose if the EEG is suppressed in this setting. The other option is secondary decompression. That means that decompression is done after recording an high ICP. It's a very old story. It wasn't a secondary decompression at the beginning of the previous century. And the maneuver have different fortune because it became a very diffuse therapy, has been stopped and then restarted again. We have a lot of local problem linked to the surgery. We will not go in deep detail in each of them, and we have two large trials published on big journal, the Rescue ICP and the DECRA study. And I think we are using more often the secondary decompressive craniectomy nowadays because we call the surgeon, it depends on the technique has been chosen, but you increase the side, opening the dura also, increase the side in which the swollen brain could expand. But if you look at the result, the problem of the result did open a couple of discussions in the community. The first one is that if you look progressively the patient till 24 months, there is an increase of positive outcome over time, mainly in the surgical patients. So the patient, we are used to focus on the first 6 months, or in some trials also earlier. But if you follow up the patient longer, you will discover that the patient still increase their performance over time. We have a reduction of the mortality of the 3 time points, and the discussion mainly is ethical about the severe disabled population that did not die, but moved from a black box, so died patient to patient with severe neurological damage, so not independent at the bedside. Hypothermia is the last option. We had a lot of discussion in Seattle, and I saw David in the first row. He was one of the proponents to keep hypothermia in the 3rd level option, but the mechanism is similar to the barbiturate with less side effect, probably. There are many trials, very old, some new, but what can we say? That the early prophylactic hypothermia, like all the other prophylactic maneuvers in TBI, are not suggested, and the trial comes from Australia. There is no benefit in applying hypothermia to patients, nor on the clinical exit outcome, nor on control of ICP. And the trial from Peter Edlund, the Euro-term trial, demonstrated the possibility of having a worse outcome in this setting, but the entry criteria wasn't a third 3 therapy level, it was an earlier entry after the first bolus of mannitol. So it was the discussion we had at the beginning of this trial, and we don't have the result, and applying the therapy probably too early is the discussion we have with David, is linked to severe damages. When we start to use this kind of therapy, this is a crucial point because in a recent review we tried to be simple, like a traffic light, green, orange, and red. So we can say we have normal ICP, we have high ICP, and we want to be below the threshold of 22 millimeters of mercury, and we have some critical value of a 25 when we can start thinking about using more severe approach. But probably here lies a problem we have in the interpretation of the data we got from the past. From the Traumatic Coma Data Bank, and Anthony Marmaru said to us that the time spent over the threshold is one of the main determinants of outcome. It's not going over the threshold 1 minute, but staying more time is linked with worse outcome. But we are simple men or simple women, and we say 20 is the threshold, because was the statistical threshold that Anthony defined, and the guidance said you need to start a therapy when you go over 20 or over 22, applying the new criteria coming from an epidemiological study, from a retrospective study from Cambridge. So 20 or 22 is the same, but we did miss the time. And if we look at the data coming from Seattle, you can see that the time spent over ICP, you can probably cannot see the number. Here is 14, here is 20, here is 25, more than 25. Mortality of the population is not binary, over or below 20, but going up is associated with increased mortality. And the same we saw with the brain-IT collaboration. As you can see, this is a transition line between good and negative outcome. And it is not only ICP, by the time of exposure is quite important, because lower levels are associated with mortality if the patient stay at lower level for a very long time here, sorry. But also the other point we start to consider is that the threshold depends also on autoregulation. Patient not able to have a good autoregulation have a lower threshold of treatment. So we need to put all this information in our treatment, and this makes the situation more tricky, because we like to have a single threshold for all the patients, 20, but 20 is not the goal number we apply to all the patients. Which are the result of this therapy? Because I want to say that there is a lot of confusion in the application of the third-tier therapy. These are data from the Center TBI collaboration. ITIL, high therapy intensity level, 31% of the patient. Many patients did get some high intensity level therapy. But look at this graph, this caterpillar plot. There is the possibility for similar patients to have 2 times higher application of third-tier therapy compared to other settings. And you probably cannot read this slide. This is the percentage of appliance of ICP higher than 50% of the patient, and this is the line in which there is high T level, low therapy, high intensity therapy level. And it's not the association is not so clear from the patient with the center with an higher incidence of inserting an ICP and having a high aggressiveness on treating the patient. The same applies with similar number to center, aggressive to treat the patient, but not used to use secondary third-tier therapy. The result from the center TBI looking at the unfavorable outcome, so a Glasgow outcome scale of 4 or below 4, says that there is an increase of the possibility of having a negative outcome. And if you look at the sensitivity analysis and you look at the ITIL therapy, the number is close to 1. So there is the tendency of having a more negative outcome in patients with this kind of therapy, but they are more severe. And if we exclude the patient with barbiturates, this effect goes up. So it means that probably the patient that have barbiturate that respond to the therapy still have some metabolism, and controlling ICP probably is more beneficial. Chiara Robba already presented to you some results we analyzed from the synapses studies, and these are day 1, day 3, day 7. These are extreme therapy in red, mild or moderate TIL, basic TIL, so the standard therapy. And as you can see, because we exclude the decompressive craniotomy, early decompressive craniotomy, not secondary event, you can see that across the week, not so many patients were exposed to high-level therapy, so around 20% in this setting. And if we look at the therapy we saw in our collaboration around 2,000 patients, 100 with monitoring systems, so we are analyzing them. So extreme suppression, hypocapnia, and extreme hypothermia were used in the early phase, but decompression, this line, was the most preferred strategy during the week, day 3 and day 7. What we saw about the result, there is a lot of transition of care, because some patients remain without therapy. Most of the patients had a mild approach, and over the week, the percentage of patients exposed to extreme therapy was similar. As you can see, some patients recover and they return back to a lower level of therapy, and some patients did increase over the week. So we changed the number of patients in the red box of this slide. And looking at the result, compared to the patient with extreme therapy level, that is our reference point, if we look at the probability of having mortality or unfavorable outcome, look at mortality, we can see that the patient with no or basic treatment, including patients that the clinician don't want to treat, so the patient we are not able to save and we stop the therapy, the probability of having an outcome, a mortality, a similar mortality, is quite similar, the same of mild and moderate TBI. And the same apply also to the Glasgow Outcome Scale Standard, as you can see in this slide. So the main lesson that I want to discuss with you in the last minute are that probably we need to define a better threshold, but during the first week, we use extreme therapy for controlling ICP. This morning we discussed the need or not need of having an ICP device. In severe cases, you cannot go so high in the therapy level without an ICP. But in the selected cases, probably we need to consider the use of third level therapy, discussing with the family the possible outcome, mainly when we use the compressive craniotomies, as we saw in the Peter Hutchinson study. Thank you very much for your attention.
We have time for a question. Anybody?
On pregnancy. On trauma in the pregnancy, I'm able to respond.
Maybe one question regarding barbiturates and burst suppression. So we use similar treatment in the operating room, but typically when we reach burst, we would probably stop at this point. So do you use burst as a way to monitor the amount of barbiturates?
Absolutely. The effect we are searching is the reduction of ICP, so we are looking at it. But for reducing the dose you are applying to the patient, because you are reducing the metabolism, when you got the depressed EEG as bus suppression, as you saw, you can have a longer or shorter bus suppression, but at the end of the day, you need also to avoid the secondary effects of the drug, so hypotension, immunosuppression, and so on. So you limit the dose according to the bus suppression, but even if the target is the ICP. So we use both ICP control and treating the dose with the EEG monitoring or compressing the EEG, whatever you want, some electrical activity indication.
Thank you.
Thank you very much.
Thank you.
And finally, I'd like to introduce David Menon, who from Cambridge, who will talk to us about how has outcome improved.
Thanks very much, Sujin. So thanks to all of you for staying here late, but it may just be because the exhibition and the drinks are starting soon, so I have no illusions about this. Okay, so I was asked to talk about how has outcome after TBI improved. I've modified the title, as you can see, has outcome after TBI improved, because I think that's more apt. And the first theme is to concentrate on how we measure outcomes, what are the instruments and what are the relevant thresholds that we would use for this. So in general intensive care, it's very straightforward. You treat a patient and then you see whether the patient's alive or dead. Typically it's been so far 28 days, but people are increasingly going to 90 days, which is better than 28 days. But we know that patients can survive with brain injuries from a variety of causes and have devastating neurological deficits. So mortality is not an adequate outcome threshold. So we tend to use the Glasgow Outcome Scale Extended. It used to be the Glasgow Outcome Scale, which was 5 levels, and now 8-level Glasgow Outcome Scale Extended. And typically, in many trials and also in our clinical work, we used to think of this as the threshold. Above that is dead or dependent, and below that is independent. And that was thought to be a favorable outcome below, and above that was an unfavorable outcome. But we just need to think this through. If I go into just to give you some idea of that, if you look at the biggest trial that included all of these patients with all severities of TBI, mild TBI of GCS 13 to 15, the dead or disabled proportion was 10%. In moderate TBI, it was 25%. In severe TBI, in the CRASH trial, it was 60%. But the point about this is that it also depends on the severity of the injury. And the sorts of patients that Giuseppe was just talking to you about require phase 3 therapies. It may not be appropriate to want to accept patients who have completely independent existence and need to think a little bit more about what a GOSE-4 is, which says dependent needs some help. That means the person can be left at home for at least 8 hours and is independent at home for that time. They can't go out and do their own shopping, but under certain circumstances, that may be an outcome that's worth having. But if I go into an intensive care unit with TBI, what I want is to be below this threshold. I want to fully return to normal life. So increasingly, not just for mild TBI, but also for moderate and severe TBI, people are recognizing this phenomenon of incomplete recovery. And I think that is certainly something to aim for, to use as good a quality of recovery as you can have. And that the idea about having all of these things is important because you're calibrating the outcome expectations in the top with the red threshold, the most severe TBI, requiring extreme therapies. The gray is the most common dichotomization. And the rational outcome dichotomization for mild, perhaps all TBIs, and certainly for Menon, who requires intensive care for his traumatic brain injury. And these have some clinical rationality because if you think about the analogy to cancer, we have different aims when we treat localized tumor versus metastatic tumors. In the former, it's to cure. In the latter, it's to extend life. And it's societally meaningful because independence at home for 8 hours, as I said, allows a child, a partner, or a parent to maintain a job and actually maintain some quality of life for themselves as well. And it's acceptable to many patients. After the Rescue ICP study, we published a paper here from Saiben and colleagues showing that that kind of a survival is certainly acceptable to many patients who achieve it. There is no buyer's regret. It isn't that they say, I wish I'd never had a decompressive craniectomy. But the problem is this, that we focus primarily on the GOSE, and this from the National Academy of Sciences and Engineering, NASEM, in the US, has described this biopsychosocial-ecological aspect model of TBI outcomes, making the point that it's not just the physical deficits, but it's the psychological reserve that the person has, what are the social networks that support them, and what are the ecological factors in terms of what's the healthcare system. And trying to put all of this together, at least at the patient level, we can't specify what the local health system is going to be like, means that using this, a global outcome scale, GOS, GOSE, perhaps some quality of life is not enough because outcome is multidimensional and you have to start with recovery of consciousness, certainly physical functioning, neuropsychological impairment, health-related quality of life, TBI symptoms, particularly after concussion, and psychological status, and 30% of our patients develop depression and PTSD. So the next challenge is integrating the GOSE as our primary endpoint into a wider panel of outcome measures. And this is an analysis which was done for the Lancet TBI Commission update, which was published late last year, done by Lindsay Wilson. And what you have is an upset plot where you're looking at the relationship of each of these instruments, PCL5 for PTSD, anxiety, PHQ-9 for depression, Colibri-OS for quality of life, Rivermead post-concussion questionnaire, and the GOSE. The first thing I'll say is that it's very unusual for you not to have an abnormal GOSE, an impaired GOSE, but have something else associated with it in terms of symptoms of having a complete recovery. And in fact, only 3.5% of patients are symptomatic at follow-up with a GOSE of 8. So they said, I'm back to normal life, but when you ask them specifically, they said, no, I'm a bit depressed, I've got some symptoms left over. So the functional qualification with GOSE, surprisingly, turns out to be a very good framework to hang outcomes on. And in a paper we published in JNNP a little while ago, Lindsay, Wilson, and some of us put together this using the GOSE as a framework at which you decide what are the other assessments you need to do. At the top end, for example, as our patients are recovering from coma, the most important thing to do is not a GOSE, but a CRSR, the Coma Recovery Scale Revised, as devised by Joe Giacino and his colleagues at the Spalding Center. And then as you go to the top end, these patients who have a GOSE of 8, but still are symptomatic, then you need other assessments, which are probably only reasonable in terms of research context. So you have a range, but you can use the GOSE to hang those additional instruments on. And you can also use that to pick up patients for so-called symptomatic therapies. So for example, arousal agents in the patients who are still comatose or in a disorder of consciousness, and cognitive enhancers at the bottom end. So one last thing, and I should make this point, that endocrine deficiencies are very common. They're not part of this framework, and we should look for them because they're eminently treatable, and if treated, can make a big difference to the quality of life. So what are the current expectations of outcome? So I've talked to you about the various instruments we might use, but what are the current expectations of outcome following TBI? And this is from the Center TBI study. The core study had inclusion criteria of a suspicion of TBI, indication for CT, presentation within 24 hours. The only exclusion was if you had pre-existing cognitive deficit, which would make assessment of outcome difficult. What you have is the core study with just over 4,500 patients split into 3 strata. For the purposes of this audience, over 2,000 patients were in the ICU, and most of them, nearly 1,850 patients, were available for follow-up. So in this group of patients, we have at 6 months post-TBI, mortality of overall 12.4%. In the ER stratum, these are patients who came to the emergency room and then were sent home from there, 1.3%, admitted to the ward, 5.5%. ICU population, these are not necessarily severe. 30% of our patients had mild TBI here, had a mortality of 21%. The unfavorable outcome in the ICI population was 43%, and the less than complete recovery, remember I said GOSE less than 8 was 84%. And what that tells you is, if we look at this in another way, that the unfavorable outcomes are only 25% overall, but nearly 2/3 of patients have a less than complete recovery. In the mild TBI population who are so well that they come to the emergency room and are sent home without being admitted, nearly 30% of them have an incomplete recovery at 6 months. That's a substantial number. But equally, what you can see is that when you look at incomplete recovery in the ICU population, these are patients who are so sick that they were admitted directly to the ICU, either for intracranial or extracranial causes. Over 15% of them are back to completely normal at 6 months. So these are people who have made full recoveries. What about quality of life? Well, if you look at the impaired scores on the short form 12, mental component score, which is a nice summary of mental recovery after TBI, or the physical component score, you can see that there's much more uniformity. That gradation that we saw in the objective assessment wasn't there. And similarly, in the quality of life, it does scale a bit with whether you were an ER patient, admission patient, or ICU patient, but nowhere near as much, which means that patients are much more accepting of these deficits than we think they should be, and they're happy to carry on with their life. Their quality of life is not as bad as you'd expect it to be. So we need to refine our stratification of what constitutes a favorable outcome and better assess the mechanisms that are responsible for functional deficits and quality of life that they affect. So what are these things? And I'll just talk about a couple. The first is this, So the other thing that Lindsay did within the Center TBI data set, again in a paper in JNNP, is we took these three components. We took the cognitive deficits, which is in blue, the physical component summary from the SF12, which is in green, and the mental component summary from the SF12, which is in red, and saw how they scaled with the GOSE. For the reference population, we thought about using an orthopedic trauma, but they didn't have quite the same exposures as our patients did. So we took the people who had recovered completely, had a GOSE of 8, had a GCS of 15, and nothing on their CT, as the people who had the most similar experience, but had not sustained a significant TBI. And what you can see is that the physical deficits, the green line, pretty much scale with the outcome. So the worse your physical deficits, or the other way around, the worse your outcome, you're more likely to have physical deficits. The mental outcome scores scale with the level of outcome, but flatten out at the bottom end, perhaps because people are unconscious of these deficits and are less aware of them. But what was interesting was that if you looked at the cognitive deficits, they were abnormal. They were below the reference population, even in the GOSE 8 patients, but stayed pretty flat. But as you went from being independent to dependent, you had a big change in cognitive deficits. So what it looks like is that the cognitive deficits are common even in good outcome, but stable to upper moderate disability, and they may drive worse outcomes. So treating these cognitive deficits may not just be something at the top end, we need to think about it at the bottom end as well. The second thing we need to think about as ICU physicians is this, the withdrawal of life-sustaining therapy. We had over 2,000 ICU admissions over the age of 16 years. The ICU mortality was 13%, of which 86% died after withdrawal of life-sustaining therapy. And that's pretty much work that is replicating results from Canada and other centers as well. We dichotomize this as early or late, depending on a 72-hour threshold, and early withdrawal of life-sustaining therapy was seen in 50%, mostly in severe TBI with abnormal brainstem reflexes, but not all. There were no regional or center influences. 50% of the patients who had withdrawal of life-sustaining therapy. So you look at the bar graphs here, and that's early withdrawal of life-sustaining therapy, and that's the median expectation of an unfavorable outcome. So these patients, 50% of them had a 1 in 5 chance of having a favorable outcome, and they were still being withdrawn on. And the question we have to ask ourselves whether this is appropriate or a self-fulfilling prophecy, and we strongly caution against early withdrawal of life-sustaining therapy when there's doubt. If you've got bilateral dilated pupils, a devastating CT, it's one matter, but if there's doubt, we should hold back. So we come to the question that we have here, has outcome improved? Well, there's some data suggesting that mortality has improved. So this is from Sherman Stein. It's a paper that was published in 2010, so nearly 15 years ago now. And this is the modeled mortality, depending on the year of study, going out to data up to about 2005, so nearly 20 years ago. And what you can see is that mortality has been steadily reducing, and then when you model it in low-intensity and high-intensity centers, the high-intensity centers have a lower mortality than the low-intensity centers. So, okay, so we are appearing to do what we're trying to do. But what about functional outcome? If you look at functional outcome, it's a much more mixed picture. When you look over time, the slope, both, and this is combined for high and low intensity management centers, the slope is not statistically significant. It seems to be flat. But that doesn't quite fit with a lot of data that's coming out from individual centers where protocol-driven high-intensity therapy is associated with better outcomes. And I'm not clear how to make sense of that disjunction. But what we do have are data suggesting that if you look at what happens with high-intensity therapy, so this is looking at neurocritical care centers versus non-neurocritical care centers, but I think it probably is talking about protocol-driven therapy, and there are previous meta-analyses as well. So this is for mortality, and what you can see is that there is some reduction in mortality, but it's not hugely impressive. And anyway, we're not that interested in mortality for reasons we've talked about. When we look at functional outcome, there seems to be an odds ratio. You're dropping the point estimate to the hazard ratio is 0.83. So about a 20% improvement in having unfavorable outcomes, suggesting that protocol-driven therapy as we've talked about before, but appropriately following protocols may actually result not just in improvement in mortality, but also improvement in functional outcome. How does this translate to our present experience with center TBI? So this replicates something that Giuseppe showed you from the SYNAPSE study, but it isn't center TBI. This is looking at the median odds ratio for the Glasgow Outcome Score across different centers. And it doesn't separate out very much. They're very close together. The median odds ratio here for the ICU patients was 1.2. But if you go 10 years or 15 years ago, the median odds ratio in Hester Lingsman's paper in neurosurgery was 3.3 for European centers. So if you were in a bad center, you had 3 times or more the risk of having an unfavorable outcome. So this looks very much like we've gathered up and we've become much more efficient at actually treating our patients and are doing better with that. But when we look at mortality and functional outcome, this is what we see, that we're exactly as Chairman Stein showed, that the outcomes are better in terms of mortality because this is the impact risk prediction model with the predicted risk of mortality on the x-axis and the observed mortality. And you can see throughout it's below the diagonal line of identity, suggesting more patients are surviving. But when we look at the core impact model for functional outcome, it calibrates pretty well still, even though these models were produced over 20 years ago. So we need to think about whether we're making a difference to outcome. It doesn't tell the whole story because case mix has changed. We've heard about frailty, comorbidities, complex extracranial trauma, and these are not fully captured by the impact covariates. So the jury is still out as to whether we're improving our functional outcomes. Finally, a point about timing and therapy choice. So you see here what the TRACK TBI study did in terms of the various outcomes over time at 2 weeks, 3 months, 6 months, and 12 months. And what you have in this line, the bit that's yellow is mortality, the bit that's green is independent survival, and the bit that's pink is alive but dependent. And the worry for us as intensivists is that we're going to save these lives, but they're going to have terrible outcomes. But that doesn't generally seem to be the case. What happens is mortality increases, patients get better, and over time, the number of disabled survivors gets reduced. They either die or get better, and that may go on for some time. But you also have the data from the US TBI Model Systems Project, which is just looking at recovery of consciousness, which is something of real interest to intensivists because we worry about patients leaving and whether they'll be in a vegetative state. And when they looked at these upwards of 16,000 patients, these are the patients who left the unit still in disorder of consciousness, and those are without a disorder of consciousness. Sick patients, 35% of them had a craniotomy or craniectomy. They had stayed in the ICU for 25 days on median. But when we look at the recovery of consciousness, when they were admitted at rehabilitation, that was the proportion who were still in a disorder of consciousness, but that got better at rehabilitation discharge. And in fact, of the 2,000 or so patients, 40% of them became partially or fully independent by the end of rehabilitation. So these are patients who are leaving our ICUs looking like death, not very well warmed up. But when they get to the point of leaving rehabilitation, they're at least partially or fully independent. And delayed or slow emergence is far commoner in TBI than other causes of DLC. And finally, the point that Giuseppe made with his decompressive craniectomy, but presented slightly differently. This is the Rescue ICP trial with outcomes at 6 months, 12 months, and 24 months in the surgical arm and the medical arm. And I've drawn these lines showing the GOSE of 8, in this case 7 and 8, so good recovery, and now a more conventional dead or dependent rather than the one we used in Rescue ICP. And you can see that for the patients who were in the medical therapy arm, they pretty much were stuck. A few patients got better, whereas in the patients in the surgical arm, as time went on, more and more of them became independent. So the story is not over till it's over, but you have to have the intrinsic ability. You can't be old, you can't have comorbidities because you'll require a long time to recover, and that's when you should think about these phase 3 therapies. So I'll finish by acknowledging the center TBI population who, not so much the patients, but now the researchers. When we started center TBI, it was over 80 institutes and over 100 researchers, but when we finished, This was the authorship on our core TBI paper. This is truly team science. So thank you very much to all the people who participated.
Thank you. That was so valuable. I'm okay. We went over because we got so much information. If anyone has a burning question, you can stay and do it, but I know that the abstracts are soon, so we understand if you leave. But any questions from the audience? Yes, please.
Return to work and return to driving is often a surrogate marker of recovery. Do we have any data of GOSC 7 and 8 of what percentage of patients return to work and what time points?
So one thing I should have said about GOSC, there's a difference between the GOSC that we collect in Europe and in North America. So in North America, in track TBI, they looked at the deficit purely because of TBI, which they call the GOSC TBI, and the GOSC all, which could be peripheral injuries as well. So GOSC 8, I think, is reasonable to assume that they have returned to work because it's compared, all your GOSCs are compared to your pre-injury status. GOSC 7 is a little more difficult to say. We do have the data on whether they return to work or not because that question is there in the GOSC list of questions. I can't tell you that offhand. I can look it up, Deepak, and let you know later. Thanks.
All right. That concludes our session. Thank you so much for your attention.